It is
Myers.
being recorded.
I'm the director of compliance for CTS and Trinity. This is our annual required clinic emergency disaster preparedness conversation. So this is a summary of the emergency disaster preparedness manual, which should be in all of our departments, whether you are a freestanding clinic or if you're part of a larger CCRC, if you're on a campus with a skilled nursing facility. In the past, it has been a red flash drive on a red string, so it's easy to locate. But we are having conversations about adding the entire manual to the shared drive in 365. So you don't have to keep up with the red flash drive. We don't have to remember getting it out to a new clinic when we do make updates to it, because we do review it annually. When we do make updates to it, we don't want to have to come out and update your flash drive. So hopefully first quarter of 2026, those little flash drives will be, if you even have one, will be a thing of the past, and you guys will be able to just access the emergency policy manual in the shared 365 files for both companies. But what we're going to talk about today is going to be a summary of that. Obviously, we're not going to go through the entire manual because it's pretty big, but I do want to hit things that you guys are going to be most likely to encounter in your clinic. So this is a summary of what's in that emergency disaster and preparedness manual if you should ever have to access it. As all hazards planning and preparation, all hazards response. So what we're going to do in the lead up to this situation, and then what we're going to do to recover, specifically fire prevention and response, severe weather preparedness and response, terrorism, meaning really any kind of, explosion or situation that's occurring near or in your clinic, be it something that's planned or something that's an accident. It covers miscellaneous hazards and emergencies. And then regardless of what goes on and what our response is going to be, how can we recover after the incident? How are we going to maintain the safety of our staff, our clients, anybody else who is in your clinics, and then get back to normal operations as soon as possible? So our mission with all of this is to, with respects to emergency preparedness, we don't want to have this conversation. We don't want the first time this conversation to be happening is when there's actually an emergency in your clinic or in your building or in your facility. We want to go ahead and start thinking about what could happen now. We want to plan, prepare, and respond to emergency situations and disaster scenarios. We want to ensure that the casualties and property damage are minimized. And by casualties, I don't just mean deaths, unfortunately, but any kind of injury to you guys, to your clients, or to anybody who else is in the clinic. We want to minimize that. And again, we want to restore normal operations as soon as it's safe to do so. So the purpose of all of this is to provide an all hazards approach to guide in the event of an emergency, a crisis, a disaster scenario that would affect the safety and well-being of our clients and employees. The desired outcome is to protect the clients, employees, family, anybody that's in your clinic from a variety of emergencies. And, obviously we can't plan for everything that could potentially happen, but we want to cover the things that you are most likely to encounter. So first and foremost, we have clinics that are independently standing buildings. We have clinics that are part of a skilled nursing facility. We have clinics that are in, multi-floor buildings. So everybody up here is probably dealing with a different clinic layout. Some of you have stairs. Some of you have to go down patient hallways to get out, things like that. So regardless of what setting that you're in right now, I want you to know, as silly as this sounds, but especially if you're new with us, what the clinic floor plan is. In the CTS clinic in Laurinburg, that's going to be a very different situation because that's a very small building with very few rooms than it is in the clinic in Dunn, which is like a big maze. So what are the location of the exits? Not just the official exits, but anything that you could use to get out of that building in an emergency, windows, sheetrock, things like that. We're going to talk about potential exits later on another slide. Location of fire alarms if your clinic or your building has that. Location of hand sanitizer kiosk. location of fire extinguishers, and then location of any kind of PPE. And in general, location of anything that you're going to need to respond to any emergency situation. We need to know that before the emergency actually happens. So when we're talking about our actual incident system, we're not going to go through the exact procedure with every single scenario that y'all can be presented with because they're all going to be very similar. But I want y'all to get your head around the concept of an incident command post. So where are you guys going to meet when an emergency happens, regardless of what that emergency is? Our policy says that that should be the program manager's desk, but I really don't care where that is. In some clinics, the program manager desk is right, in the lobby when you walk into the front door, and that may not be the most appropriate place. So if your program manager's desk is not going to be your incident command post, so where everybody meets to determine what you're going to do in response to this situation, y'all need to go ahead and determine what that is. There also needs to be an incident commander. So who is going to be in charge of this situation and make the decisions and put all of this in place whenever an emergency were to happen? Again, we're going to assume it's the program manager, but if it is a lead therapist, if it is your, you have billing people on site, whoever that is in your building, we need to determine an incident command post. So where everybody is going to meet in the event of an emergency, regardless of what that is, and an incident commander. So who is going to be in charge when something were to go wrong? Not just that, but we need to elect backups. What if, because of this emergency, the incident command post is compromised and, the ceiling has fallen on the program manager's desk? Where else are y'all going to meet? What is going to be your plan B? If your incident commander, i.e. your program manager, is on PTO, then who is going to be your backup? So you need to have, your incident command post, your incident commander, a plan A and a plan B for both of those situations. Currently, a copy of the emergency management plan needs to be kept at that secure location if it is on the red flash drive. But again, that is eventually, or hopefully very soon, going to be able in a shared drive on 365. Copies of the emergency management plan. Again, I think that we've done a pretty good job with getting that out to everybody, but with it being on 365, that should not be an issue. And then again, as I mentioned previously, we have a compliance committee that meets quarterly, and annually at least we do review and update any policies and procedures that have to do with emergency policy. So that's another reason for it to be shared as opposed to on a flash drive in case we need to get updates out to you guys. So when something happens, our response to it could be separated into evacuations or shelters in place. So this is something that happens suddenly. You guys are already at work. You're already seeing patients. Something happens, and we need to get out of this building. That is an evacuation. We don't need to, again, wait until that situation happens to talk about it. So we're going to talk about it right now. We're going to prepare for evacuations well in advance. A lot of times it's something that you could see coming, like a hurricane. A lot of you guys, if there's a hurricane coming or a flood or a blizzard, you're probably not even going to be at work. So this may not even be applicable to you, but we're still going to talk about it. Evacuations, so again, could be planned or they could be spontaneous. You didn't know anything was going on. You're at work and you're in the Dunn Clinic and the train that is right across the street from your front door derails into the lobby. This clinic is going to prepare for evacuation well in advance of a crisis or disaster situation requiring partial or complete evacuation, regardless of whether the evacuation is planned or spontaneous. The clinic understands that if a community-wide or a regional disaster, so again, like a hurricane is occurring, the clinic, y'all may need to be prepared if you are already at work to be self-sufficient for a little while because, emergency response may be delayed, or if it's something that the clinic is closed, that may be for a prolonged period of time, unfortunately, versus a shelter in place. So the clinic plans for a shelter in place also well in advance of a crisis situation. That's what this conversation is. We are going to identify and assess the length of time it can realistically support a shelter in place before a decision is made to fully evacuate. And a lot of this stuff is probably, once an emergency happens, you're not going to have a lot of time to consider all of that stuff. So it's another reason why we are going ahead and giving thought to this sort of thing. Why you would do a shelter in place versus an evacuation. You have an active shooter that comes into your clinic or any other kind of unwanted entry. You know, it may not be somebody who's coming in with a weapon. They're just coming in with fists ready to fight. A tornado or a natural disaster that you didn't see coming or any other kind of emergency. So think about in your clinic, whatever building that you're in, what are safe rooms that you could shelter in place in? It needs to be something that's structurally sound and away from any of generally you want to be as far away from the danger, being that weather or a person. Put as many walls and doors in between you and that person or that threat as possible. So maybe that's a treatment room, maybe that's conference rooms, maybe it's bathrooms or closets. In the Dunn Clinic, which used to be a bank, y'all have a safe. So that seems like that would be a pretty good place to shelter in place from like a tornado or an earthquake, provided that you don't shut the door and lock yourselves in there. Because I don't know if anybody has the combination, so don't do that. But the decision to shelter in place is determined by the program manager or the incident commander based on the safety of the situation. So what is our procedure going to be for a shelter in place? So again, our response for any of these is going to be very, very similar. So I'm going to go through these a little bit more detailed and maybe apply some of this to future emergencies. But if possible, if we have enough time to sort of plan, we're going to get together at something has happened. We need to gather at the incident command post. The incident commander is going to make the decision about what we're going to do. We need to identify who's in the clinic, not just your clients or patients or kids or whatever you call them, but also their caregivers, who's there to pick them up, who's there to visit. A lot of our policies or all of our policies, like number 2 or number 3, is going to be to notify Kim, your area director, myself, whoever, when it's safe to do so. Obviously, that does not need to happen. We need to make sure that everybody is safe and that we have a plan in place before we're notified. Don't necessarily drop everything and put yourselves in danger or your clients in danger to notify us, but it is part of our policy. You want to notify everybody as much as you can. You want to notify anybody in your clinic that something is going on and that they need to shelter in place. You're going to instruct all visitors, vendors, volunteers, anybody that is in your clinic or in your proximity that something is going on and where they need to go for their safety. Unless there is an imminent threat, provide staff, anybody that's in your clinic, with a time frame. You know, how long are we expected to stay? Give them an opportunity to communicate and let you know. Hopefully they've got their own cell phones and they can communicate with exterior people, but they need to be able to, if this is a kid, then we're going to need to be able to communicate with their caregivers that something's going on. If possible, close and lock all windows, exterior doors, and any other openings to the outside, especially if it's somebody that's outside trying to get in. We don't want to invite them. And if there's a danger of a potential explosion or wind or anything like that, if possible, close the shades, the blinds, or the curtains. So pretty self-explanatory. In addition to like the incident command post and the incident commander, what we talked about last year whenever we were going out and doing this, I challenged everybody to identify at least one room in your clinic. And again, this is going to be different for all of you because you're in all kinds of different shapes and sizes of buildings. But select an interior room, preferably on the ground floor, with the fewest, if not no, windows or vents that could be like a safe room. So you're at work and the tornado shows up. Where can you safely go that, you know, especially if the incident command post is compromised, that everybody just knows immediately that something has happened and we need to go to that room. In a lot of clinics, there is a room that is obvious. There's an indoor or like a conference room, like in Dunn has multiple conference rooms, multiple offices that are small interior rooms that do not have a lot of windows and doors. So think about that place if you know where that is. If you do have to go to it, you want to avoid overcrowding by selecting several rooms if necessary, if that's possible. Things like large storage closets, utility rooms, pantry rooms, kitchens. If you're in Dunn, you're safe. Without exterior windows, all of that works well. Avoid selecting a room with mechanical equipment such as ventilation or blowers because if something is going outside, we don't want that air coming into your safe room. And if anybody anymore in the year 2025, 2026 still has hardwired telephones. It would be nice if, wherever your safe room is had one of those in case your cell network is down and you need to communicate with the outside world. If this shelter in place is initiated due to an internal threat, such as an intruder, we want to shelter in place as long as possible, but as soon as it is safe to evacuate through the nearest exit window, through the sheetrock over the wall, we want to do so. We want to bring everyone in the area of safe refuge, shut and lock the doors. If the threat is internal, barricade the doors if possible, and then get on the opposite side of a piece of furniture, then the doors and the windows, in case that person or that threat would be successfully coming through the door or the window. Then at least you have another barrier of furniture that is keeping you safe. Ensuring accountability and keep track of all clients and staff members. Obviously, we don't want to be losing a kid or an elderly person in the middle of this emergency. And then after all of this is over and everyone is safe, we want to evaluate client status changes and needs, especially if the power is lost. If you've got people that, we can't communicate with their caregivers, we can't communicate with the facility, it may be up to us to ensure the safety and the well-being of our patients. So if there ever is a situation where you guys, whether it is an evacuation or you are sheltering in place and you do make the decision that you need to get out of the clinic, I want you to go ahead and decide for your clinic an external meeting location. So we've all scattered outside of this clinic, we've all scattered outside of this building. Where are you going to meet up to ensure that all of your staff, all of your caregivers, and all of your patients are safe? So when I've had this conversation with other clinics, there's a bank or a grocery store that's right across the street that they know that they're going to assemble at. There's a nearby parking lot. There's a big oak tree or a big McDonald's sign or something like that they know that everybody is going to meet up. Go ahead and determine where that location is. Do not wait until something is going on. And then some of you are at the basketball court and some of you are at the McDonald's and some of you are at the bank and we don't know where everybody is because the cell phone network is down. Go ahead and determine where you guys are going to meet up in the unfortunate situation that y'all need to get out of this building. So the most common things that you guys are going to probably experience or be exposed to, unfortunately, obviously, fires. All personnel should learn methods of fire prevention and must report conditions that could result in a potential fire hazard. So maybe the best fire prevention, the fire response is to prevent it altogether, including using electrical equipment and cords correctly, especially in this time of year when you've all got Christmas trees and space heaters and things like that. Managing any flammable materials if you have anything like that in your clinic. Avoiding accumulation of trash, not just from a fire hazard, but also from a safety and a tripping hazard, things like that. There's a variety of reasons we want to be avoiding that. And then avoiding any open flames or smoking in the building. I can't imagine why. Well, I mean, candles, we need to be careful of that because that could result in a fire. If you're smoking inside your clinic, there's a lot of reasons why that's not a good idea. So please stop doing that. If there is a fire, we're going to report it. Some of your clinics or some of your buildings may have an actual fire alarm that you could pull that's communicating to the fire department directly. But even so, and especially if you don't have one of those fire alarms, we need to be prepared to call 911 if ever a fire were to break out in your building or your clinic. When you do call 911 and you have to talk to the fire department, you need to be prepared to tell them the type of fire. It's electrical or, trash is caught on fire or something like that. The exact location, the extent or the size of the fire, what you guys are doing in response to it. Are we evacuating the room? Are we evacuating the building? Is somebody in danger, etc.? And then any other kind of important information that is necessary or requested. As with any time you are calling 911 and communicating with police or dispatch or fire, remain calm, speak in a clear and distinct voice, follow any instructions that they issue, and then keep the phone lines open. We don't want to be making any unnecessary calls unless they need to call us back. We've all heard of RACE. So there is a fire that is big enough that we need to respond to it because it could be putting you guys or our patients at risk. We're going to first rescue. We're going to, everyone in the immediate danger we need to move them to a safe location away from the fire. We're going to alarm. So we're going to activate the building's fire alarm system by pulling the nearest manual pull station. Or if you don't have that, you're going to call 911. Everybody probably has the phone on them or nearby. You're going to confine that fire, make every attempt to confine it to the room of its origin by closing the appropriate doors. And then if it is safe to do so, after we've done the above 3 steps, we could make an attempt to extinguish it with a fire extinguisher. If you do need to use the fire extinguisher, we've talked to people last year that had never been exposed to one and didn't know how to use it. So in generalities, this is how you use it. You're going to pull the pin. You're going to aim the nozzle at the base of the fire, not the top. You're going to squeeze the lever, and then you're going to sweep side to side until the fire is extinguished. If it is safe to do so. It is not safe to do so, then we're not going to worry about that. We're going to evacuate. A little bit more about electrical device safety because of all of your Christmas trees and space heaters right now. We want to protect clients, patients from any injury associated with the use of electrical devices, including electrocution, burns, those things setting the clinic on fire, including it's all the stuff that your parents always told you. Do not pull the cords. If you're unplugging something, you want to unplug it from the actual plug as opposed to pulling the cord. You don't want to plug something in or unplug it with wet hands because you or the client or whoever's doing it could be electrocuted. Inspect electrical outlets, extension cords, anything like that, light switches for damage. If this is a electrical socket or a light switch that has black soot coming out the top of it, that's probably a problem that somebody needs to correct. So if you are using space heaters, as I am right now, it's very cold here, they shall be used with caution and away from any combustible items in the client's environment. Extension cords and power strips do not need to be used as substitutes for adequate electric outlets. So we've all seen the thing like from Christmas Vacation where the one power strip is overloaded with, the one outlet is overloaded with power strips and electric cords. We want to avoid that because that is a fire hazard. So that's fires. Severe weather. So we're at work, and there are clients in our treatment area, there are caregivers in the treatment area, and severe weather were to come up. First of all, how are you tracking that? Some clinics have a regular radio. They may have an emergency weather radio. A lot of places have televisions in their actual treatment space or in their lobby with the news going. So if there is an emergency alert, then that's going to pop up on TV. Again, most people have their phones with them or close by that they're going to get some kind of phone alert that if there's any kind of emergency situation. But if you know that something is going on, that there's a tornado warning or something, consider weather spotters. You actually got somebody in the window looking for funnel clouds, or if your community has sirens to indicate these sort of things, somebody needs to be on the lookout and listening and looking for that sort of thing. As far as inclement weather, the most common thing that most of us are going to be exposed to is the possibility of tornadoes. So establishing procedures to inform personnel when tornado warnings are posted. Again, the program manager, whoever is at the front door, knows that there is a tornado warning. How are they going to communicate with the therapists and the assistants and everybody else that's in the clinic that may not have their phones on them? We need to establish that. We're going to go ahead and establish a safe place within each clinic if you have not done so already, and consider the amount of space that you need, which is going to be different if you've got a full clinic and full staff as opposed to it's 4 o'clock and there's only 4 people in the building. The best protection in a tornado is usually an underground area or a basement or a ground floor if your clinic has access to any of that. If an underground area is not available, consider small interior rooms with lowest floor without windows, hallways on the lowest floor that do not have doors and windows, any room that's constructed with reinforced concrete, brick, or block with no windows and heavy concrete floor or roof system overhead, and just in general, the sturdier the walls that are more internal, that are free from doors and or free from windows and have the fewest number of doors are going to be your best bets in a tornado. This may seem silly to include earthquakes in this talk, but I'm old enough to remember we did actually have an earthquake that we could feel in North Carolina, I'll say 15 years ago. So we're not outside of it's not an impossible situation that we would have an earthquake. But again, a lot of the same policies to follow it as what we just talked about with a tornado. You want a sturdy room. You want to get under something that's sturdy. With earthquakes, one of the biggest things is that you want to avoid being beside heavy furniture, a heavy bookshelf, a bookshelf that has something heavy on top. Underneath a TV, anything that is going to fall on you or a client, we want to avoid being near that. Bomb threats. So you're the program manager, you're at the front, you're the therapist that answers the phone, and this is somebody who is calling in a bomb threat. We need to be able to respond to that. We want to try to keep the caller on the phone as long as possible by asking the questions outlined in the telephone procedure, which I'm going to talk about on a future slide. Again, as soon as it's safe to do so, notify us, but that could be moved down if it's not safe to do so. We're going to activate our incident command system, the post, and the incident commander. Upon any threats or warnings regarding explosives in the clinic, as soon as that person says that there's a bomb in the clinic, that is an immediate call to 911. That person needs to stay on the call, but as soon as it's safe to do so, everybody else needs to be walking around the clinic looking for anything that is suspicious. You want to do that discreetly. You don't want to be running up and down the hallways, scaring clients or their caregivers, but look for any unusual or extraneous items, boxes, packages, bags that you don't recognize or that are not typically there. If you do find that stuff, do not disturb it because it may be explosive or it may be tainted with something. Immediately evacuate everyone from any unusual or suspicious item and immediately report all findings to the incident commander. Coordinate all actions with law enforcement officers if you've already called 911. And if a suspected bomb is located within the building, obviously law enforcement officials have jurisdiction and then they take it from there. So I said the bomb threat telephone procedure on the previous slide. This is what it is. So we want to keep, if you are the one who takes that call, keep the caller on the line as long as possible. Ask them to repeat the message. If you have some kind of way of doing it on your landline or your cell phone, you can definitely record the call. At the very least, record the start and end times of the call. Ask the person his or her name. They may be stupid enough to give it to you. If the caller does not indicate the location of the bomb or a possible detonation time, the person receiving the call should ask the caller to provide this information. And it may be helpful to inform the caller that this is a pediatric clinic that's full of kids. This is a CCRC or a skilled nursing facility that's full of old people. So if you actually did put a bomb here, you're going to injure a lot of people because it may be a prank and that may be enough to talk them down. So more about suspicious packages and biohazards. A lot of this has already been covered on the previous slide, but if we do find something that is suspicious, we're going to contact 911. Again, do not touch it. If you do touch it accidentally, we're going to wash our hands with soap and water because we do not know that if it's tainted with something. List all people who were in the room when the suspicious letter or package was recognized and give a copy of this list to the local, to anybody who's asking for it. If 911 is contacted or anything like that. If there is exposure with a biological agent, you want to take any kind of necessary anti-contamination steps that you need to take. It may be that you need to go home and take a shower or quarantine your clothes, et cetera, et cetera. Instruct staff members, clients, and visitors to remain in the clinic until further notice from the local authorities if that were to happen. Continue to listen for official instructions via television or emergency alert systems for further instructions. And as always, we're going to account for all staff members and clients and anybody else who's in your clinic. So in the event of terrorism or not something that is man-made, again, this is, you're in the Dunn Clinic and a train derails across and then there's an explosion. Anything that is, happens like that outside of your clinic, this is what this pertains to. We're going to, however you do it, be it texting or yelling down the hall, we're going to notify the staff that something has happened. We're going to instruct staff and clients to get under or next to a sturdy table or desk if debris is falling, if your actual building is compromised. We can notify the area director when it's safe to do so. That's not necessarily number 3. If the explosion occurs or is adjacent to the clinic, we're going to activate emergency evacuation procedures if we need to evacuate our building. Avoid all areas where there are large ceiling spans. If the explosion was bad enough, that's going to be the most likely. If there's some kind of structural compromise to your clinic or building, the bigger rooms are going to be at risk of the ceilings falling on people. Small rooms or interior hallways away from windows and doors are suitable for taking cover in a situation where immediate threat is present. If taking cover in a hallway with a door or a window at the end of the corridor, stay like 30 feet away from doors or windows in case there was going to be another explosion outside. If safe to do so, we need to put our whole incident command post, incident commander situation in place. If we are taking cover, obviously you want to remain calm, ensure your clients are safe, make sure that anybody else in your clinic, their caregivers, people who are there to pick them up, people there who are there to visit, are all taken care accounted for. Maintenance staff should prepare to activate shutdown procedures if warranted by the situation, and all other staff members immediately secure the work areas by securing records, closing drawers, where if this is a situation where we're going to be permanently or for a prolonged period of time evacuating this building. If you are near clients, those are our priorities, not our records and not our equipment. We need to be any staff member who is nearby clients, be they therapists or administrative staff, need to be the ones that are relocating the clients and ensuring their safety. If you are in a building that has stairwells, which some of you do, those are ideal places to, if there's some kind of building compromise, those are typically the most sturdiest places in your building is a stairwell. If someone is trapped, so this is now a situation where a building is structurally compromised or in the process of collapsing, encourage that trapped person to use a flashlight to signal location or the flashlight on their phone. Avoid unnecessary movement as not to stir dust. Cover their nose and mouth so they don't breathe in any kind of hazardous material. Avoid yelling out and things like that. They could tap on a pipe, tap on a wall. If for whatever reason they've got access to a whistle or any kind of alerts on their phones, that would be ideal for them to be found by emergency, anybody who's responding to it. Regardless of where they are, in this situation, all client, staff, and visitors are going to remain in that refuge area until the incident commander or the 911, somebody that is responding to the emergency, determines that the danger has passed and determines an all clear. And after all of that, after it's safe to do so and the incident is over, as always, we are accounting for all staff members and all clients and anybody else who may have been in your clinic. All right, so few things that seem sort of far-fetched and maybe something, I don't know how often you've had to be exposed and plan and respond to an earthquake, or a terrorist attack. But now we're going to talk about some things that probably everybody in here has had some kind of exposure to. Unmanageable clients. So we do want each client or patient or kid, whatever you call them, we want them to be provided a safe place of treatment, but that doesn't mean that they can come in and act or their caregiver act however they want to. Should a client or their caregiver's behavior become abusive, hostile, assaultive, or unmanageable in any way or would jeopardize his or her safety or the safety of others, the program manager and or therapy staff member should immediately provide for the safety of all concerned. So not just that person, but your client, all the other clients, all the other caregivers that are in your clinic, move them away, move the equipment away from the person who's in there, acting up. And notify the client's responsible party. This may be a kid that you guys can sort of manage their, unruly behavior, by yourself, or this may be an adult if you're an adult clinic that may need nursing intervention or their spouse to come down. Should the client pose an immediate danger or become violent or beyond the control of the clinic, do not hesitate to call 911 or to call the facility administrator if you are in an adult setting. Don't be afraid to tag out if you guys need assistance. We don't expect anybody on this call to be a hero and put themselves in an unsafe situation. Every effort shall be made to calm the client. However, y'all's personal safety, the client's personal safety must always be considered. Unmanageable clients may not be retained by the clinic. So if this is bad enough or this is a repeated thing, we can discharge that kid or we can discharge that person. We do not need to, willfully be putting our staff and our other patients at risk because of someone's behavior. Should a client's behavior become uncontrollable, the therapist and or program manager does have the authority to contact the client's responsible party and require that a family member of the family remain with the client until the client calms down or be removed from the facility or the clinic. And then if something like this does happen, obviously we have all kinds of incident reports that need to be filled out, especially if it results in some kind of injury to a client or a team member. All that I just said about caregivers and clients also pertains to our staff. It is the policy of this clinic that all employees, clients, family members, visitors, contract, anybody in that building enjoy a positive, respectful, productive, and safe environment while on our premises. A lot of this is overlap with the corporate compliance stuff that we talked about earlier in the year. Any kind of violent acts we have zero tolerance for: verbal or physical harassment, verbal or physical threats, assaults or other violence made directly or indirectly by words, gestures, or symbols, any other behavior that causes others to feel unsafe, like bullying, sexual harassment, and or the possession of a weapon on the company's premises. Our goal is to promote an environment free of behavior, actions, or language causing or contributing to workplace violence, harassment, or bullying. It is the violation of clinic policy to possess, use, or threaten use of a firearm, explosive, or other dangerous weapon on our premises. Inappropriate reference or threats to use of knives, letter openers, box cutters, hooks. That's in our policy. So apparently we have a pirate in one of our clinic who has threatened someone with a hook. It is unacceptable and may result in disciplinary action. It is the responsibility of all employees to notify the appropriate supervisor or HR director of any threats which they have witnessed, received, or been told that another person has witnessed or received. So remember our reporting procedure. We all maintain an open door policy. If you have seen something or you have been a recipient of any of this, we expect that to be reported so we can follow up on it immediately. We also have the anonymous reporting hotline. So if you don't want to give your name, if you want to make an anonymous report, you have that avenue also. Employees who in good faith report that they believe to be that they have either observed or been the recipient of aggression or violence and who cooperate in any investigation will not be subject to retaliation. Again, remember, like we talked about with corporate compliance, if you bring a concern to us, even if we find out that it's all a big misunderstanding, there is no retaliation for good faith reporting. However, violators of our workplace aggression and violence policy will be subject to disciplinary action and, if warranted, criminal prosecution. So as with most things that are violations of our compliance program, the best bet is to avoid committing any of those and violating our policy. If we are in a situation where someone comes into your clinic, if you watch the news, there's a lot of conversations, especially right now, about active shooters. So you may have that situation, or somebody who's coming in with a knife or just, being threatening. How are we going to respond to that? Early and immediate recognition of an active shooter or armed intruder is imperative to increase the survivability chances of staff and clients, i.e., do not wait until that person comes into your clinic. If you are in the lobby, or if you're at the program manager's desk looking out at the lobby and this person is out there and they appear threatening, or maybe you see them with a weapon, go ahead and lock the door. Do not wait until they actually come into your clinic to put all of this in place. Notify staff of the intruder or the active shooter verbally or via electronic message or phone. Call 911. We're going to implement our incident command system. Again, notify us whenever it's safe to do so. Notify the client's responsible parties, if not on the premises, as soon as it's safe to do so. Again, if possible, we're going to initiate clinic lockdown procedures, preferably when this intruder or this this threat is outside before they get into the clinic. But if they are already inside, depending on the location, we need to be initiating a shelter in place. But if it's safe to get out of the building, especially if the person is already inside, we need to do so. So I've been through a lot of active shooter trainings, and they all sort of say the same thing. These are the things that they promote, not just in a situation where you're at work, but if you're out in a restaurant, you're in a mall, or if you're at a beach in Australia, these are things that they are promoting to improve your likelihood of getting out of a situation like that successfully. Situational awareness to your people and surroundings. Is somebody being threatening? This is a parent who has threatened to come in, or has threatened harm against mom, has threatened harm against a therapist, and that person actually shows up at your clinic. Do not take their threats as idle threats. We need to, if they have been threatening, certainly if they verbally, but certainly if they've exhibited any kind of threatening behavior and they show up in your clinic or they show up in your parking lot, then we need to go ahead and take that seriously. Any kind of warning signs, like again, they're communicating threats, they've been through stressful situations, a divorce or a bankruptcy or a termination or something like that. Evacuate if possible, but know all possible exits. So what we talked about on one of the first slides is where your actual exits are, where that door is that you come in and out of every single day with the big red fluorescent sign on top of it that says exit. If something goes down in that clinic, that's not the only way maybe that you can get out. There was an active shooter situation. This is the example that they gave us, and I thought it was a good example. And I can't remember the specifics of it, but active shooter walks through the front door, barricades that door, and starts going down the hallway, intimidating people. Everybody comes out of their office and runs towards that one main entrance that's barricaded and can't get out, and he shoots them. On both sides, to the left and the right of that exit that was barricaded, were windows that those people could have broken out. So in your clinic, in your building, consider things like that, not just your official exits, but how could I, if that exit is compromised or if it is barricaded, is there some other way that I can get out? We don't mind if you break windows if you have to. We do not mind if you go through sheetrock. We don't mind if you have to go over, the ceiling tile that you can move and you have to go over a wall. Anything like that is going to improve your odds or your client's odds of getting out of there successfully, we encourage you to do. If evacuation is not possible, secure your room, lock the door, get behind, barricade the door from the inside. Again, put you and your clients behind a piece of furniture that is between you and the danger that may be coming through that door. Developing a survivor's mindset. Don't just, cuddle and, huddle in the corner where you're going to be easy pickings. Think about improvised weapons. You are in a room with a fire extinguisher and that threat comes into the door. Now you've got something that is going to shoot. If you've ever shot a fire extinguisher, all this white or yellow goo and cloud comes out that could obstruct their vision. And now you also have a big red blunt object in your hand that you can throw at them while you get away. So consider things like that. A missing client. So something has happened, or this is just a client that just says they're going to the bathroom or something and they don't ever come back. So once we identify that this kid or this adult is missing, and this is going to be situationally specific, right? Because, your building or your clinic, it may be easier for somebody to get away and hide in some clinics than others. But once we realize that this person is missing, we're going to notify everyone about it. We're going to note that the last time that we saw this person and when we discovered that they were missing, we're going to implement our incident command situation, mainly because we need all hands on deck to go and find this kid or this adult. Anybody who can, these are therapists and assistants that aren't currently working with other clients, they can help search. We need to notify the client's responsible party that they're missing. Initiate a thorough search by staff members to locate the client. If the client is not located, proceed with the following. So we're going to instruct all staff to search the entire clinic, the grounds, If you're in a freestanding clinic, any neighboring streets or alleys, assign each staff member a section to search in order to minimize overlapping or overlooking an area. When conducting a search, it is important to look under beds, furniture, in walk-in refrigerators, in closets, under desks. Some of you CTS clinics, some of your clients may be very small and can fit into very small places. So think about everywhere that they could have gone. Being thorough is extremely important. And then once you have searched your whatever a section is assigned, then you're going to notify the incident commander. But if the search is unsuccessful for a period of around 10 minutes and the responsible party has been notified, then we're probably, especially if this is one of the pediatric clinics, we're going to need to call the police or notify the facility administration for further support. If the police were to arrive, we're going to provide them with a picture of the client if we have that, or any other kind of pertinent information such as what they were wearing, how they're ambulating. So are they in a walker? Are they in a wheelchair? The client's cognitive status. Information is where the client may be going. This is an adult resident who was talking about going to McDonald's, and there's a McDonald's close to you. Maybe they were, acting out on that. When the client is found, we're going to notify all staff members so we can all stop searching for the person, examine the client for any kind of injuries, and then contact the family or the responsible party, the administrator if you are in a facility, and inform his or her status, ensuring that all of the above steps are documented in the medical record or on an incident report if that is necessary. Document the incident and events objectively in the resident record, including, any kind of details about the incident. If you were exposed to any kind of blood or body fluids, a lot of this is covered in more detail in our annual bloodborne pathogens. So I'm not going to go through this with a whole lot of detail, but basically we want to avoid any kind of blood to blood, blood to body fluid contacts. If that is on you, you're the staff member, and you come in with some kind of significant cut or skin wound, we expect for you to be taking care of covering that so it's not going to get on anyone. If it is a patient who comes in and they've got a wound or a scrape or dermatitis or something like that, we expect any kind of necessary actions to be taken to cover that up as well. We expect staff to wear protective clothing when providing treatment to a client with a potentially contagious bloodborne illness. Should skin exposure to blood or bodily fluids occur, the employee should stop the procedure as soon as it is safe and practical to do so. Wash the exposed area thoroughly with soap and running water. Report to your supervisor. Fill out and complete an incident report and an employee injury report form. It's getting hard to talk. And obtain further counseling from the director of HR or compliance regarding any kind of possible exposure to bloodborne pathogens. If the skin exposure involves large amounts of blood or prolonged contact with the blood, especially if the exposed skin is chapped or otherwise broken, use alcohol or peroxide to further wash the wound after you have done normal hand washing. If the exposure to the blood or body fluids occur in the eyes or mouth, a lot of places have the emergency eye wash centers that look like water fountains. So use those, rinse your mouth with peroxide or whatever is safe to do so. If any of that occurs, as with anything else, report the incident to your supervisor and complete the incident report or the employee injury report. Should an exposure to body fluids occur from a needle stick or from a sharp instrument, maybe you're a clinic that's doing some kind of wound debridement and you're working with scalpels. I don't know if that's any of our people, but just in case, allow the wound to bleed freely. Wash the exposed area with soap and water. Apply antiseptic as desired, whether it's alcohol or peroxide. Report it, incident report, and then get in contact with me and the director of HR, regardless of whatever company you're in, regarding the exposure. So another thing that we talked about in emergency management to take it further. So we just talked about, cuts and scrapes and things like that. What if this is a situation that leads to a bigger bleeding event? So it is unfortunately like a gunshot wound, or this is a tornado and some kind of debris or a nail or something like that has gone in and caused somebody a significant bleeding situation. The number one way to improve the client's survival in that situation is to minimize bleeding. A lot of our clinics have these bleeding control kits, or your facility may have a bleeding control kit that involves a tourniquet, wound packing material, a seal sucking, the seal sucking, I don't know what that is. It looks like a piece of plastic that's going to go over a sucking chest wound, but consider use of that. If you are using a tourniquet to reduce bleeding of a limb, like an arm or a leg, so not a neck, we're not putting it on anyone's head, but if this is a limb that has a significant injury and you are using either an official tourniquet or a belt or a necktie or something like that, you want that tourniquet to be high up on the limb. You want to get it on fast as possible, and you want it to be as tight as possible. This is not going to be comfortable for the person, but even though it's painful, it could save that limb or their life if we're going to reduce the bleeding. So you want that tourniquet to be tight enough that you're not going to be able to feel a pulse in that limb anymore, that whatever wound is actively bleeding is going to be tight enough that that wound is going to stop bleeding. If this is the next picture down here with the bullets, this is, something, either a bullet or a nail or a piece of wood that has gone through someone. The bleeding may not be coming from the superficial wound that you can see. So that's where either your facility, or if you've got one of these bleeding control kits, have wound packing gauze. So you want to pack the wound because the bleeding is coming from all of this internal damage, not necessarily from the superficial thing that you can see on the skin. And again, if this is an injury to the thoracic cavity, so especially lungs, heart are involved, that's going to create a sucking chest wound. So you want to provide this seal that is going to provide an airtight situation where their lungs are not going to collapse until the EMS can get there. Not going to go into a whole lot of details about CPR. A lot of you are CPR certified, and we definitely encourage that. But if you're not, I've been a party to multiple situations where our staff have had to do CPR or some kind of rescue breathing, things like that, to clients. So really consider that. If you're not required to do it, I definitely think it's a good idea to do it. I just looked it up before this call, the current breaths to chest compression ratio is 30-2, so 2 breaths to every 30 chest compressions. All of this is here in the policy. Again, I'm not going to teach y'all how to do CPR, but if it is indicated, please provide it. If your clinic or your facility has an AED, I think it's a good idea to use those. If you are providing CPR, if you are providing some kind of basic life support, you want to continue that until EMS arrives or the facility nurse arrives or whatever to relieve you. Lastly, choking. So I think that this may be the most common thing that we have dealt with, either or that we have a risk for. Either you're working with a pediatric clinic with feeding, or they're just putting things in their mouth, or you're working with an adult client that is feeding. The risk of choking is there. So again, not going to go through the Heimlich maneuver, but we do want some common things to remember if this is a choking incident. First of all, if they're still able to talk, if they're still able to cough, then they are not fully choking. That is going to require like a Heimlich situation. You want to encourage that person to keep coughing. You want to encourage that person to keep talking, anything like that. So as soon as they can no longer cough, or as soon as they start to turn blue, or certainly when they lose consciousness, we want to initiate the Heimlich maneuver, which is the fist right beneath their xiphoid process of their ribs. Other hand comes up and you're going to provide forceful upward contractions to try to expel that agent. If it's an adult, if it's a kid, you're going to use the one fist. I've got a picture. If it's the smaller client, you're going to use the one fist, or if it's a baby, you might even be using a couple of fingers underneath their xiphoid process to provide the strong upward pressure to their diaphragm to try to expel that situation. If they do lose consciousness and they're lying on the floor, this picture here of this lady in the pink scrubs is how you continue to use the Heimlich maneuver to try to expel that foreign body out of their mouth or out of their esophagus until nursing or until emergency personnel can get there. As soon as that item does appear in their mouth, we want to do a mouth sweep. We want to remove that foreign body out of the person's mouth, out of their airway as soon as possible. Before any of this happens, hopefully we've already contacted nursing, we've already contacted 911 if we need to. And then if the person does require CPR or they do require an AED, then we have put that into place. All right, I was able to do that by one as promised. Any questions or comments or anything like that about anything that I talked about, anything else that I did not bring up, any situations that you have questions about that you think would benefit the group? So like I've been talking for an hour and have not taken much of a breath either. All right, so some housekeeping things. I sent out to everyone this in-service sign-in sheet. I need one of these for everybody. This is mandatory for all staff. So if you have staff members that were not able to get onto this, or if you have somebody who is going to be newly hired between now and the end of the year, this is a requirement, this webinar. So I need facility, clinic name, date, and anybody who has participated either live or they've watched the recording. I need copies of this. They need their printed name, their signature, and then a copy sent to Chastity if you're CTS or Tammy if you are Trinity as soon as that is completed. All right, if there are no other questions, that's all I've got. I appreciate everybody's time. Hope everybody has a great Christmas and New Year's and stays warm. And let me know if anyone has any questions.